Good morning, everybody, and welcome in our beautiful city, Cairo. Let me give my appreciation to the European Association for the Study of Diabetes for the effort and everything done to make this course happen here in Egypt. This is the first time in Egypt, and we are very honored to have you all distinguished professors and speakers. Thank you very much, and for the audience, I hope you're going to benefit a lot from the course. Thank you very much, and now Professor Leszek.
Good afternoon, or good morning, everyone. My name is Leszek Czupryniak. I'm currently the chair of Postgraduate Education Committee of the European Association for the Study of Diabetes. And we're delighted to be able to come here. We, for the first time ever in Egypt, although it's not the first time we are in the Arab community. We are delighted to be here, not just because of this great city, country, history, your hospitality you're famous for, but also because that's one of the most important places for diabetes research and care. There is hardly any other place in the world where diabetes is more prevalent than in Arab Arab countries. So we try to be present regularly in this region, we call in Europe, Middle East, but we also go once a year to the Gulf countries. Last year we were in Jordan. We also travel to places like Iran. Regardless of any politics, we simply talk to the doctors and meet doctors who look after the patients with diabetes. With your high prevalence of this disease in your country, I hope, as it was just said, you will benefit a lot, but we also learn as European Association what more can we do to work together more and for the improvement of health of our very numerous patients. The course is one of our regular activities. It's the last one we will have in this calendar year. We run 10, 12, up to 13, 14 courses per year. It's a lot of activities, also an effort on part of our part, local organizers, the faculty who comes here, and we always point out we are not paid for this activity. We don't get any honoraria. We do it as a kind of a service, and also being a part of the AASD. How important it is for the AASD, I have a very good piece of evidence, because the first talk will be delivered by Professor Andrew Boulton, who holds almost all possible functions in the AASD, including the president. He's the immediate past president of our association. So as you can imagine how busy he is, he still finds time to take part in postgraduate activities. So this is a long-term project. In a way, we realize we started in the early 70s, and we will continue. And as I said, the places where we have so many patients with diabetes are always on the top of our agenda where we travel. The course consists of lectures and workshops. We strongly encourage you to stay with us for the whole duration of the course. The location is magnificent, probably too magnificent as for the meeting like this, because there's a lot of temptation to see the city, but you can always do it either, not in the breaks, but perhaps immediately after the course. We try to compile the program which will fulfill your needs. It was done together with local organizers. We worked on it. There are also local speakers. Feel free to ask any questions after the lectures or workshops. It's really as much as we could do and talk with you, answer your questions, discuss your experience with treating diabetes, all challenges, then we will know that we did something useful. So thank you very much for coming, and we're very much looking forward for those next 3 days together. Thank you.
بسم الله الرحمن الرحيم. It's a great pleasure for me to co-chair with the EASD postgraduate course, and I am very happy to find most of eminent professors in this field, and some of them I see them for the first time. I hope to have a good 3 days to know more and more about the diabetes and its complications. Thank you.
Bismillah ar-Rahman ar-Rahim. I would like to thank this magnificent group of elegant speakers coming for free to teach, to help our patient, teach our doctors. It's a great pleasure to be with you in Cairo. Our first speaker is an eminent one. No ever event for diabetes, whether in EASD or whether it is in ADA or IDF, and Professor Boulton is always present and is always giving his magnificent lectures. His talk today about diabetes and obesity, the 21st century epidemic. Professor Boulton works and is a professor of medicine in University of Manchester, UK, and University of Miami, Florida, in USA. I don't know how he can manage, but please, Professor Boulton, your talk.
Shukran. Salam alaikum. It's a pleasure to be here in your country, and I'm somewhat ashamed to say it's my first visit here. And my first impression arriving at Cairo Airport is that London Heathrow could learn a lot from you, because it's much more efficient. So it really is an honor to be here in this wonderful city, and I'm going to kick off with this talk on diabetes, the 21st century epidemic. Now, our former Chief Health Officer in the UK, Sir Liam Donaldson, said these words: "If you always do what you always did, you will always get what you always got." In other words, we need some change, and that's certainly true with our approach to diabetes, the global epidemic. And here is a paper some 8 years ago from the British Medical Journal talking about the global burden of diabetes. And it stated that for the first time in our history, non-communicable diseases have become the leading cause of global mortality and morbidity. This was 8 years ago. This is a world atlas, and you see here the physical geography of the world, and if this pointer doesn't work, so we're over there in the middle in Egypt, and you can see this is according to the physical geography. Now, if we change that map to the population distribution, we see a vast lot of people living really in Asia and also in the Middle East area. If we do the same for the diabetes distribution across the world, then we see a similar division with a huge prevalence of diabetes again in the Asian area, India, China, and it was felt then that India was number 1, China number 2, and United States number 3 in terms of global prevalence of diabetes. But it was this study from China that was published a few years ago in the New England Journal, a proper designed population-based study, that showed in red there that in 2007 to 8, just under 10% of the Chinese population were found to have diabetes. Now, if their population is 1.3 billion, that's 130 million people with diabetes. And the worrying thing was that many of these were undiagnosed were found out to have diabetes in this particular study. Here are some data that I found from your country, in Egypt. And it was reported 2 years ago that this was the 9th highest prevalence globally, that the prevalence of diabetes has tripled in the last 2 decades, and also in type 1. And the prevalence of diabetes in this country in the adult population was reported to be 15%, which is of course extremely high, and for your country it means a huge burden of chronic disease, and of course economically as well. I was just in August lecturing to the Pakistani meeting by Skype to Islamabad, and my good friend Abdul Bashir and Samad Sarah told me that they'd just completed their study looking at the prevalence of diabetes in Pakistan, a population-based study completed this year. And this is unpublished, and they're going to publish it, but the frightening facts were that 26.4% of the population in this study was found to have diabetes. This means that there may well be nearly 50 million people with diabetes in Pakistan. These are very worrying data. But it's not only type 2 diabetes, there is an ongoing increase of type 1 diabetes, and this study from Finland, which has the highest incidence of type 1 diabetes in the world, shows that this continues to increase. And these data published last year from the United States, a study of insured patients in less than 18 in young people with diabetes over 2002 to 2013, shows that the prevalence of diabetes had increased by 52% in the young population of the United States. Increase in type 1 diabetes was 57%. But we're beginning to see in the UK and the USA young people, teenagers with type 2 diabetes. And the prevalence of type diabetes in pediatric population was highest in the 12 to 18 age group. So it's a global increase of diabetes we're seeing type 2 and type 1. And if we look at these data here from a paper in Nature Reviews Endocrinology just last year, the change in the global numbers of diabetes between 1980 and 2014, look at this, a huge increase. And it's due to a number of factors, as you see listed here in the bottom right. Of course, this region of the world has some of the highest prevalences of diabetes. And when I travel, I like to pick up a local newspaper while they're still available, that is, before it's all electronic. And I was on the way to lecture in Dubai in 2011, and the leading page in the Gulf News, the national page, the headlines were the cases of diabetes growing faster than projected. This is in Dubai. But not only there, I was president of EASD, as my good friend Leszek said, for some years, and Düsseldorf is our headquarters, and I flew frequently from Manchester to Düsseldorf. And I picked up this here, a focus, De Sousa Falle, the sweet trap. So this is in Germany. A report here in a German magazine headlining diabetes as a huge problem in Germany, which is the largest country in population terms in Europe. So we have a war against diabetes, a global war. And during any war there are many battles, hopefully won, not lost. National, regional and global. So we need a national, international policy for diabetes, to raise the profile of diabetes as a serious condition across the world that should be taken seriously. Now, soon, the next global atlas of diabetes will be published at the IDF. These are the data published in Vancouver just under 2 years ago at the IDF meeting. And look at the projections that are already an underestimate. 1 in 2 adults with diabetes is undiagnosed. And adults who died for diabetes as a consequence of diabetes, 5 million are there, which is more than those dying from HIV, AIDS, tuberculosis, malaria, infectious diseases. So this is a global problem. So there is an urgent global need for policies that promote prevention, primary prevention. Can we identify high-risk groups and prevent them from going on to get diabetes? Secondary prevention. Those patients who already have diabetes, can we prevent the late complications from developing, and so on. This was a paper by my friend Professor Ronald Ma and colleagues from Hong Kong, published last year in Diabetes Care. The global burden of diabetes. The rise of type 2 diabetes in South Asia was predicted to be 150% between 2000 and 2035. They described this as a rising global public health tsunami. So, messages that we need to give to governments and the world at large is that we cannot afford to ignore diabetes because the human and economic costs will be too great. Diabetes consumes up to 15% of national healthcare budgets. In some countries, it's as high as 40%. Of course, a large part of this is due to the late complications, which we will be discussing. Now, I was very fortunate last year to share the stage in Bangalore, India, with the Prime Minister of India there on the left, Sri Narendra Modi. And he was an impressive speaker. He got up and said to this audience of 15,000, no longer are malaria and tuberculosis the biggest threat to our survival as a nation. It's diabetes and chronic diseases, non-communicable diseases. And he's right. So in some countries there is a realization that we need to act now to save catastrophe later. And here we see an atlas, again, looking at the prevalence of raised blood sugar aged 25 years and above in females. And you see the highest prevalence, again, in this region, red and brown. And this coincides with the prevalence of obesity. Again, it's not just countries around here, North America, even Iceland there, surprisingly. Now, it was some years ago that this article appeared in The Age, which those of you who've been to Australia will know is the national newspaper in Melbourne. And this was when our good friend Professor Paul Zimmet was starting his studies of the Polynesian islands, looking at the distribution of diabetes. And this was the headline, "A Western Killer Let Loose in Paradise." Now, I don't want you to think that Professor Zimmet's in prison for mass murder. Of course, the Western killer is diabetes. And the island of Nauru is a classic example of where the prevalence went from nearly 1% up to about 35% with coca colonization, if you like. And he talks about coca colonization of the world, acculturalization, modernization, and contributory factors are seen here. Again, if you look at the age standardized prevalence of obesity in all age groups, but worryingly at the bottom in children, we're facing a global disaster. Obesity in children is rising. Now, this gentleman is sitting on a fire hydrant, as you see at the famous Wrigley Field in Chicago. And this is what we call the Diabesity Epidemic worldwide. A large prevalence increases in both nations, both developed and developing, due to social, environmental changes, globalization, if you like. And it's one of the biggest and most serious challenges to public health in the 21st century. Now, looking at this gentleman here, sitting on that fire hydrant, I was worried about the safety of the fire hydrant, actually. It was quite a large BMI sitting there, and I was worried that he might end up getting a large enema if there was a burst pipe. But apparently he survived. Now, look at the, if you like, the competition. at the bottom there, and you have to say that the USA is probably the most generous in funding for research in diabetes. And therefore the budgets for the Center for Disease Control in Atlanta, for the FDA, about $6.4 billion. But look at the opposition. Advertising spent on food, confectionery, beverages, cars, 4 times more. And of course, this promotes sloth, if you like, in other words, not doing too much. Here is a headline in the British Medical Journal some 15 years ago. Obesity is an epidemic without treatment. And here, if you like, is the development of mankind to McDonald's man in the 21st century. This has to be in the United States, and I think one could not doubt that this is true. If the gentleman did have anorexia, then he certainly got over it. And this, if you like, is the ultimate in inactivity. How to walk your dog, drink a Coca-Cola, and watch television without expending any energy whatsoever. And this is the problem we're facing. So, obesity, diabetes, there is a genetic vulnerability. Insulin resistance, impaired glucose tolerance, as you know, hyperglycemia leading on to diabetes. But there are opportunities for intervention, for prevention, all the way along: prenatal care, adolescence, adulthood, maternity, old age. At every step in our lifetime, there are possibilities to reduce this huge impact of disease. Here's a paper this year, Childhood Obesity and Analysis in 200 countries. The Global Obesity Childhood Study that shows increases, huge increases in obesity in girls and boys. Huge increases. Despite this, having said that, across the world more people remain moderately or severely underweight, for example, in sub-Saharan Africa. So there are opportunities for intervention in early life: weight management, preconception, pregnancy, postpartum, gestational diabetes, childhood obesity prevention, and so on. So obesity and pregnancy are associated with insulin resistance and inflammatory changes. So overnutrition, maternal obesity, fetal lipid exposure, and so on. This is a paper published a few years ago. So we need to start, if you like, preconception, if we're going to tackle this problem of childhood obesity. There was a study from Finland in a city which I will not even attempt to pronounce that showed a mass program in one small town had a huge impact on reducing childhood obesity. Here's another study called the Boris study. It's not our friend Boris Mankowski, I don't think. This is showing that obesity treatment in childhood can be effective. And you can see in all age groups a reduction in this program, and published in a pediatric journal last year. There are opportunities for prevention of diabetes and early intervention in later life too. Screening, targeted screening, family history, obesity, previous gestational diabetes, and so on. Bariatric surgery, we will hear about later in this session. Advances in diabetes treatment and screening, early intervention. Look at the studies from Finland and the diabetes prevention program in the USA, highly effective. But we need to do something about this, and this is a paper I picked up on the way back from lecturing in Calcutta last year. This was the Times of India. Stop the hard sell of sugary drinks, sugar-coated danger. The prevalence of diabetes, this open letter to the chief executives of Coca-Cola and Pepsi-Cola in India, said that the prevalence of diabetes in India has doubled in 12 years. Can we please stop trying to promote what seem as sort of very attractive drinks loaded with sugar and loaded with danger? So here's perhaps a rhetorical question. Can we educate our politicians? Well, you may be surprised to hear, but Mexico is doing well. They put a 10% tax on sugary beverages. So far, so good. There's a reduction in sales, and they're beginning to see a reduction in obesity. Denmark, on the other hand, you may be surprised to hear, failed. And I was at an international meeting in Copenhagen when the then Minister of Health announced the introduction of a sugar tax. But it failed. It wasn't implemented. And people could get on the train at Copenhagen, and an hour, 15 minutes later, they're in Sweden, they buy the food and come back, avoid the tax. It failed. In Berkeley in California, a 25% tax was introduced in 2015 on high carbohydrate beverages, led to a 21% reduction in sales. The UK, well, it's always next year. And they're saying next year, 2018, we will have a tax implemented again on high sugar content sodas, if you like. So there is some hope, but taxes must be accompanied by other policies, such as advertising bans and implementation. Now, an example of what went on in the UK was that when Tony Blair was Prime Minister, he got together with a famous chef, I think it was Jamie Oliver, and they said, we're going to do something at schools, because in schools they have what you call a tuck shop, where you can buy high carbohydrate snacks, cookies, cake, crisps, high sodium, Coca-Cola. They said, we're going to replace this. We're going to remove them and have a high fiber diet, specially designed by this chef, brought in, so they're using a lot of vegetables and healthy foods for lunch, and you can't buy these things from machines in the school. Very good idea. A week later, in the Daily Mail, which I wouldn't really recommend to you, but there it was on the front page, pictures of mothers selling fish, chips and mushy peas through the railings of these schools because the children did not like the high fiber diet. So we have to start early and implement. We have to have parents on the same page fighting with us. Global diabetes epidemic. Here's an update from this June from a paper in Lancet Diabetes and Endocrinology. The global cost of diabetes in 2015 was 1.3 trillion US dollars, or 1.8% of global gross domestic product. 2/3 of these costs were direct, but 1/3 were indirect, such as lost productivity, etc. In the United States, this paper showed from Ed Gregan at CDC that of all conditions, diabetes creates the largest costs for the healthcare system. So the days of inactivity really cannot go on. We need to be proactive. We need associations like EASD, like ADA, but particularly like IDF, to be the global spokesperson for diabetes and to be seen and heard acting together as a team, working together. Now, having said all this, unfortunately no study has shown that diabetes can be delayed or prevented in a community setting. They've shown it in highly interventional studies, such as the Finnish Diabetes Prevention Program by Jaakko Toimalito, that showed clearly, as the DPP does, you can reduce diabetes by intense activity, dieting, but you don't need to go to the gym. Just walking 45 minutes a day may well be sufficient. So the clinical trials on community-based have not shown a beneficial effect. But this doesn't mean that it doesn't work. As I will tell you in the diabetic foot, I cannot prove to you that education reduces the incidence of foot ulcers. But we intuitively believe that it does, and the study will never be done, as it will be unethical not to educate people. So let me be provocative and ask this question. Is diabetes the cancer of the 21st century? We can learn. I'm not criticizing our colleagues in cancer medicine. We should be learning from them, emulating them. If you think about it, they're highly effective in screening high-risk groups. People will go for a prostate check, for a mammogram, Because they're frightened of cancer. Cancer is serious. Cancer kills you. Long-term remission and cures are possible in cancer. Similarly in diabetes, so we should learn from them. Increase public awareness. Now, I bet if you were collecting money outside this room, even at a diabetes conference, one person had a bucket, cancer research, give Egyptian pounds. Another one, heart disease, another one, diabetes. Out of £100, probably 90 would go to cancer, 8 to heart disease, and if you're lucky, 2% might go to diabetes. So people don't take diabetes seriously. So, my God, I'm going to be screened for cancer, that's terrible. But diabetes, my mother had, she was fine, she died at 93, a touch of sugar, nothing to worry about. Not true. My group in Manchester, we've published longitudinal data to show that if you have end-stage renal disease because of diabetes, and you've had a foot problem and lost part of a foot or a leg, 75% of those people are dead within 2 years. 75%. That's worse than every form of cancer, except perhaps lung cancer. So we need to change our approach to diabetes to take this as a serious, threatening disease that can be prevented. If you've got it, you can prevent getting late complications, but we need to be proactive. And in the cancer world, fear arousal has worked. People are frightened of cancer, so they'll go and have a screen. Why do people take a statin for heart disease? They don't feel any better. They're frightened of having a heart attack. That kills you. Why don't people go for a screen for diabetes and say, oh, it's a touch of sugar, nothing to worry about. Nothing serious. We've got to change that approach, but it's still prevalent across the world. So fear arousal has been effective in raising money for research in diabetes. So I think we need to change our approach. And large organizations like IDF, EASD, and ADA need to be leading this battle to change the psychological approach that diabetes is actually a life-threatening disease that we can do a lot about by preventing primary prevention, secondary, and even tertiary prevention. So we have a challenge facing us in type 2 diabetes, and the challenge isn't simply treating the blood sugar in the bottom there. There are many challenges. Can we preserve beta cell function? My center was one of the centers in the UK PDS, and we showed bottom left that 50% of all patients presenting with type 2 diabetes are hypertensive. So it's not just the blood sugar, it's the blood pressure, it's the lipids, the cholesterol. And then how do we address compliance or adherence? How can we encourage people to take medicines that may not make them feel any better, like a statin, like a beta blocker, like an ACE inhibitor? Can we prevent and delay complications, large vessel and small vessel, and so on? So it's a very complex approach. So I'll leave you with this thought from Enrico Fermi, and I hope it does not apply to you. It says here, before I came to your lecture I was confused. Having heard it I remain confused, but at least at a higher level. So, shukran.
Thank you very much, Professor Andrew, to speak about the challenges with type 2 diabetes prevalence and the increasing prevalence. Thank you very much. Is there a question or comment? Just in few minutes. Okay, then we'll shift to the other speaker, Professor Leszek from Poland, and he's going to talk about type 2 diabetes, pathogenesis, and its clinical relevance. Sorry.
Thank you very much. After this broad introduction, making a point of how important diabetes and increasingly is, I would like to spend a like half an hour talking to you on the challenge on the pathogenesis of type 2 diabetes, the area which is very much changing. We learn more and more on that, and it is simply very much relevant to how we treat the most prevalent type of diabetes. I came from Poland, Bolanda. I work in Warsaw. I'm the head of diabetology internal medicine department at Warsaw Medical University, and that's the overview of our old city. Although it's not very old, Warsaw was 95% demolished during Second World War, so everything this is rather brand new, like as if you went to US, but I hope it looks nice. The shortest definition of diabetes, and that's one of the beauties of our favorite disease, is that as much as it is deadly and complex in terms of pathophysiology, the definition consists of only 2 words, really. If I want to explain anyone who's outside medical field what is diabetes, I say, well, this is the condition when your blood glucose level is chronically elevated. Of course, there are many reasons and many roads leading to this, and I will be talking about it, but just untangling this term, chronic hyperglycemia, is a major task for current researchers. So my talk is like in 3 parts, unequal in length. How does it start, this chronic hyperglycemia in type 2 diabetes? What happens after it starts? And as every good story, I should also tell you how does it end. So let's start with the beginning. What makes people hyperglycemic or type 2 diabetic? This is a picture I took in England in a waiting room of one of the endocrinology or diabetes outpatient services, and all these 4 people here, they have type 2 diabetes. But if you look at them, you see that there must be something different in each of them. The couple on left hand side are the elderly couple, and this type 2 diabetes results in them from probably different causes than the one of the most obese person here, this man in his mid-30s, but also the one on the right, who's relatively slim, also has type 2 diabetes. So it is a heterogeneous concept of type 2 diabetes, the big bag in which we put many patients having different clinical and pathophysiological features. On the other hand, that's another picture I took in Italy at a camping site. This is a family of friends having lunch together, and if I asked you who of these people have diabetes, well, you probably would say, well, everyone, any of them could have. But actually only the man on the right in this blue t-shirt, he's got diabetes, and the other one who's sitting opposite to him, having probably a bigger belly, he does not have diabetes. So there must be something mysterious thing which makes them different, in terms that one of them has high blood sugar, the other does not. So it mustn't be that simple, and indeed it is not. A very old concept of type 2 diabetes, still in a way valid, but this is only a small part of all pathophysiology, was known years ago. This is a picture from 1993, so many years ago, showing what happens really when we develop diabetes. And type 2 diabetes is the effect of coexistence, or the result of coexistence of 2 disorders, as we know: low insulin sensitivity and relative insulin deficiency. So if you look at these curves here, and if you look at the normal glucose tolerance curve, this is this continuous line in the middle, when we get older, we move on this x-axis to the left-hand side. We move from right to left. Our insulin resistance or increases, or insulin sensitivity decreases, and as long as it is, there are many reasons for that. The one is just slow increase in weight, which occurs while we age, and when it is compensated with increased insulin secretion, then we're fine. We don't develop diabetes. We might be very obese, and there are people who are extremely obese. I could just show you at my department we are hospitalizing. We just last week the lady who's 170 kilograms of body weight. She's only 36 years of age. We will refer her to bariatric surgeons, but my younger colleagues were amazed that her blood glucose was absolutely normal. We did oral glucose tolerance test. It was absolutely normal, although she was like two men in one person with huge belly and a typical case of morbid obesity. But she produced so much insulin that she compensated her obesity. So when it happens, we're fine. People are obese, are insulin resistant, but do not develop type 2 diabetes. The moment this insulin secretion is not enough, you may fall in this blue area in this figure, which is impaired glucose tolerance, and if it is really low, this insulin resistant cannot be compensated and patients develop type 2 diabetes. And this traditional view on type 2 diabetes is still valid. We did not resign from that, but now we know much more what's behind hyperglycemia in type 2 diabetes. So sometime later, Ralph DeFronzo, an eminent researcher from San Antonio, Texas, one of the inventors of insulin resistance really, when he received his Bunting Award, Bunting Lecture, given him by the ADA, in 2008, in his lecture, he presented the view on the pathogenesis of type 2 diabetes, and first he showed this figure saying, oh, that's a very simplistic, simple, if not simplistic view of type 2 diabetes pathogenesis. Then we have the bottom two disorders, decreased glucose uptake and increased hepatic glucose productions, are clinical features of insulin resistance, and if they are associated with impaired insulin secretion, then the hyperglycemia occurs, and that's pretty simple to understand. But in the same lecture he also showed that nowadays we know much more, which I will show you also in a moment. But this simple view also makes a clear differentiation between type 1 and type 2 diabetes. Well, you would say, well, that's obvious, there are two different diseases. There are, but I will show you how they start to overlap, because we have problems with classifications in an increasing number of patients. But there is some clinically relevant difference, which is, and it's not about insulin deficiency really, which makes, in my view, type 1 and type 2 diabetes clearly different. Because both diseases are characterized by ineffective insulin secretion. In type 1, this is simply non-existing, because beta cells were damaged, and clinically there is no insulin secretion after a year or two since type 1 diabetes was diagnosed. In type 2 diabetes, insulin secretion is decreased, but it's always present. But the main difference, in my view, is rather in this insulin resistant compound, because in type 1 diabetes, insulin action is basically unchanged as long as the patient is not obese, while in type 2 diabetes, it will always be decreased. So that makes this treatment in type 2 diabetes especially difficult. In type 1 diabetes, once we start giving insulin, the effective treatment is about educating the patient and adjusting the doses to daily life. While in type 2 diabetes, when insulin doesn't work or works very inefficiently, then this is a major challenge. So that's one piece of pathophysiology which is very closely related to the treatment of type 2 diabetes. But as I said, now we know the picture is much more complex. That's a more thorough view on type 2 diabetes pathogenesis. So hyperglycemia, apart from this decreased muscle uptake of the glucose and increased hepatic glucose production, if we start from the top, we also have decreased incretin effect, which eventually was translated or is being translated into new treatments. Another feature of insulin resistance is increased lipolysis. So there is a lot of free fatty acids in the bloodstream of our patients, and free fatty acids are direct competitors with glucose as energy substrates. Kidneys uptake more glucose from the primary urine in patients with diabetes. There is a dysfunction in the brain with all the appetite regulation. Also, the overactivity of alpha cells and high levels of glucagon are often present in type 2 diabetes. So it's at this point, and this was almost 10 years ago, we already saw that these pathways leading to hyperglycemia are not just one or two, but I think you can count up to 8 arrows here. But that's again, it was almost 10 years ago, and last year we have another step forward in understanding of type 2 diabetes. The group of experienced diabetologists and researchers, one of them were the presidents like James Gavin, the presidents of the ADA. They published an article which aim was to provoke all of us to think, and they titled it "The Time is Right for a New Classification System of Diabetes," and it should be based on beta cells. It should be a beta cell-centric classification scheme. So what they argued is that, as I already said, we see an overlap of various features basically between type 1 and type 2 diabetes. We see patients who have all the features of type 2 diabetes, which is shown more on the bottom. So they are rather older, they are obese, they present something which we used to call metabolic syndrome. They have high C-peptide, higher than average sometimes. Insulin production, also subclinical inflammation could be easily found in them. And we have type 1 patients with all the autoimmune reactions, T-cell activations, autoantibodies present and requiring insulin treatment. But there is a whole area, the gray area you may call it, in between, where there are patients who are obese but have autoimmune reactivity detected, and the other way around, like the one on the right in this picture from England I show you. Patients who are relatively non-obese but also are just slightly overweight and they have diabetes already. So we are using a very simple view to diagnose our patients, but now we know that the times are about, this is my feeling, it's just my personal view, but the times are about to change, and in the next, not a year perhaps, but maybe in 5 years, we'll see maybe not the change in terms we'll be using different terms, but these classifications will have much more subtypes than we have now. And just to show you the evidence, this is the study from the Bahrain, so that's the study from Arab ethnicity from the Gulf region. A very interesting one, because the colleagues there took very young people at the age below 20, and they measured two things. They measured all of them had diabetes. The group was not that small as for young people. It was close to 300 patients. And they measured autoantibodies and they measured insulin secretion. And if you look at on the left-hand side, on the left bar here, the group 1, this is typical type 1 patients. They have autoantibodies and they have no or little insulin secretion. This is shown here as AB plus and beta minus. On the right-hand side, there is a group 4, which is classic type 2 diabetes with beta cell functioning, insulin production maintained, and absence of antibodies. But there are two groups of patients in the middle, and the group 2 are patients who also have no insulin secretion, beta minus, but no autoantibodies are detected. This was the smallest group. And the other group, which we call double diabetes, patients with preserved insulin secretion but present autoantibodies. And they are all below the age of 20. So it's not that you will have in adolescents or in children, you will have only type 1 diabetes. Majority of this group studied in the Gulf region had classical type 2 diabetes, although they are all below the age of 20. And the final element, just to make the picture more complex, and as Professor Boulton said, to confuse you but at a higher level, comes from the most recent annual meeting of the AASD in Lisbon, where the group led by Leif Group. It's a very much experienced geneticist and researcher in diabetes from Scandinavia. What they, and it is kind of a discovery they presented there, is they suggested that the patients with what we call type 2 diabetes could be grouped in several groups, and they are the differences also in clinical course of their diabetes is very clear. So what they did is they took 15,000 newly diagnosed diabetes patients and they measured 6 variables, pretty simple, age, BMI, HbA1c, HOMA insulin resistant index and HOMA beta cell function index, insulin secretion, and GAD autoantibodies, which are typical for type 1 diabetes, of course. And they measured the disease progression, they assessed the treatment and development of complications within 4 to 5 years, so it wasn't a very long-term follow-up study. So what they found out is that you can classify people which are which have diabetes into 5 groups, and I hope you can read what is in the table here. But the upper line says severe autoimmune diabetes. There are 6.5% of these patients classical type 1. But all 4 other groups are people we would call type 2 diabetes, and you can see their differences, because what they called was, they found types or patients who would fulfill the characteristic of severe insulin deficient diabetes. These patients had higher HbA1c, they quickly required insulin and had more frequently retinopathy. They also found severe insulin resistant diabetes, and these patients were at higher risk of kidney disease, not retinopathy. So whether you are insulin resistant or not affects your complication risks, apparently. The next group was mild obese diabetes, patients who had only modest metabolic disorders, and mild age-related diabetes, and this was the largest group, 40%, with also metabolic mild disorders. And that I could show you the patients of mine or whom we see at our department who could be put in each of these categories, because if diabetes is diagnosed in someone who is 78 years old, that would be a mild age-related diabetes. But they do not only look at clinical features, they also assess the presence of gene mutations, these 2 columns on the right, most frequently found in type 2 diabetes, especially TSF7L2, and this particular mutation. And this was present in 3 of these groups, while the other was present only in 2 of these groups. So we are, I think, at the brink of thinking, okay, there are different clinical phenotypes of diabetes. Those who are more likely to need insulin are more likely to develop retinopathy, those with more insulin resistant and prone to nephropathy, and so on and so on. So I don't want to confuse you, as I said, too much, but just saying type 2 diabetes is insulin resistance associated with beta cell dysfunction, it is still true, but it's only part of the true, and it's very much imperfect. In the same article I just showed you from last year, the authors also said, proposing this change of the classification, that they counted the pathways which lead to hyperglycemia up to the number of 11. And the one which are on the right, at the bottom on the right hand side, the 3 are typical for insulin resistance, so it's increased glucose production, decreased peripheral muscle uptake, and increased lipolysis. But there is also the brain which takes part in developing hyperglycemia. We know also that bacteria in the gut, here on the left hand side at the top, are important. We start to acknowledge more and more the role of subclinical inflammation, the stomach and the gastrointestinal tract role, where also patients experience higher glucose uptake like in the kidneys. But the central part of this picture says that the final common denominator, which is present in all type 2 diabetes patients, is lack of insulin. It's either lack of its function, or it's either lack of a hormone itself, and it might be due to beta cell mass, decreased beta cell mass, or decreased insulin secretion. So we would call it again beta cell dysfunction. In a way, somewhere close to here, we have defects in incretin effect and increased glucagon levels. So to treat this must be a real challenge, also must be fascinating from intellectual point of view. And in the same paper you will find the figure we've added the drugs. All those names in blue are the agents which we might use to counteract each of these pathways. Some of these drugs are not available in Europe, only in US. Some of them are not available, or minority of these drugs are available in many countries globally, but in theory at least we can combat each of these pathways. So it is a fascinating time for treating type 2 diabetes, although becoming more and more expensive for many of our patients. And just to add one more piece to the story of how hyperglycemia starts, I would like to draw your attention to the concept of maturity onset diabetes of the young, MODY, so-called MODY. That's a genetically determined diabetes. I must say, when I was preparing this lecture, I was looking through the literature, looking for some MODY, some papers or studies on MODY diabetes prevalence in Egypt or in Arab population, and I couldn't find any, I must say. But you must have patients like this, I'm pretty much sure, because it's we all humans, and we didn't have these patients in Poland either 15 years ago, but when we started to look for them, we found them. MODY is a diabetes which is caused by a single mutation in a gene which causes, for example, that insulin is not effective enough. It doesn't have to be treated with insulin, could be treated with sulfonylurea. Some of these types are not treated at all. Now we have more than 15 types of MODY, but these through MODY 1, 2, and 3 are most popular one. We slowly start calling them MODY. We call them glucokinase MODY or glucokinase disease, HNF1 alpha or 1A, and HNF4A or 4 alpha. Those HNF are hepatic nuclear factors that are responsible for insulin action on the liver, on hepatocytes. And there's also a number of genetically determined diabetes found in neonates, neonatal diabetes. If you've ever had a patient who developed diabetes before the age of 6 months, so in very early infancy, this must be the case of this neonatal diabetes, and these patients don't have to be treated with insulin. Sulfonylurea usually helps. And just to show you that they are not just researchers' invention, that's one of the recent studies analyzing various populations, mostly in Europe, which checked the prevalence in a large cohorts of patients suspected of having MODY. The typical patients for MODY, you may suspect it when it looks like type 2, it's not severe, glucose is mildly elevated, and the patient is in their 20s or 30s, is slim or just slightly overweight, and very typically diabetes was present on one side of his or her family. So everyone on parental side or maternal side has diabetes. Then you should be suspecting MODY diabetes. But if you look at prevalence, MODY 1 is not actually the most frequent. It's MODY 3 in northern populations in Europe, including my country. It's MODY 3 which we found more often now. And like in UK, but MODY 2 in moving more south, so perhaps this is the area where you could look for your patients. It needs genetic studies. 10 years ago they were very expensive. Now at my department we can check for one MODY for the cost of about 150 euro, so that's not that expensive, and we tend to find them more and more. Once you start looking for some diseases, you will find it. And it's crucial for the patients because it determines the treatment and it also determines their prognosis, which is basically quite favorable. Very few MODY patients develop severe complications. And if you're unsure, you can, if a patient might have a MODY or not, you can use this web page, www.diabetesgenes.org, MODY probability calculator. The only problem is it has been prepared from the data from European cohort, and I'm not sure how much it applies to your patients, but it cannot be that different. You put the age, and I entered some data here, like the age at diagnosis of 26, a woman treated with oral agents or insulin, but not on insulin, just with oral agents, with BMI 29 and HbA1c 6.7. Now she has 35. Sorry, she was diagnosed when she was 26. That's a real patient, which eventually came out to be MODY, and had parents, at least one parent, affected with diabetes, and the bottom line says that based on these features, the patient has a 58% chance of having MODY. So it's 1 in 1.7. So 1 out of 2 patients like that will have MODY. So you can use this just to assess the risk and then think where I could perform the genetic studies. So what happens after? Because I'm talking about pathophysiology and its clinical relevance. So once we have a patient with hyperglycemia and we decide he or she is a type 2 patient, type 2 diabetes patient, what happens after? Then it only progresses. Professor Boulton already mentioned UKPDS. This is our canonical study, which really learned us a lot, and it defined our still current thinking, although it was published 20 years ago, about type 2 diabetes. What this study found out, and it wouldn't be possible today because it would be unethical, but at that time no one really knew what to expect. The organizers or the authors of this study, Robert Turner, the late Robert Turner, now the group is still led by Professor Uli Holman at Oxford, took 5,102. This was the final number of enrolled patients into United Kingdom prospective diabetes study since the diabetes diagnosis, and they followed them for average 10.5 years. And what they found out is that regardless of the treatment used, the patients were randomized to conventional treatment, which today's would mean almost no treatment, just diet and exercise, non-pharmacological one, or insulin, or to older sulfonylureas or metformin. And one of the major discovery of this study was that regardless of the treatment used, the glucose control only deteriorated. It improved a little at the very beginning in the first year, and then it deteriorated. So once we don't treat patients like that anymore, but if we kept a patient on a single agent, his blood glucose or her blood glucose would only get worse. And what I personally find fascinating is that the angle these all curves are going upwards is basically the same. So we can hardly affect beta cell function with one agent only. Why beta cell function? I was privileged over 10 years ago to spend a few months at Oxford at UKPDS place. This is as close as I was allowed to approach UKPDS patients' data, patients' charts. This is the archives where all 5,102 patients' charts are kept. They didn't let me take out any of them and to read them. They told me that if I saw how the data were reported, I would never believe in anything from UKPDS study. So, but at least I could see them and took this picture. And I was added to the group which analyzed the change in insulin resistance and insulin secretion over the years. And as you can easily see in this figure, insulin sensitivity, as much as it was lowered since the beginning, about 50 to 60% of normal, it was more or less stable during the course of the disease. So patients had half of the typical insulin sensitivity, but this was not this element of type 2 diabetes which was responsible for the disease progression. What was responsible was failing beta cell, which improved quite remarkably by 50% when the patients received sulfonylurea. This is this red curve. But then after a year, it started to go down again. So this progressive character of type 2 diabetes is also the result of pathophysiology. Beta cells are working less and less effective, and that's why it all translates to increased treatment. But there are also some more hard data on it. This is the figure. I hope you could see the differences between left-hand side and right-hand side pictures. These are all beta cells, or rather Langerhans islets. The pictures on the left-hand side are normal islets. I took it from various papers or books. Then, when diabetes develops, if you look at the top, you have hyperplasia of islets. The islets somehow multiply with smaller size of islets, but because of the we believe that this is the way it happens, because of the increasing demand on insulin and the metabolic stress which is put on beta cells and islets in general, they degenerate, and the islets on the right hand side have many fewer cells but have a lot of this pinkish compound which is amyloid, and this is why the patients do need insulin at some stage or need some insulin secretion stimulation. The shortest route is from the one which is put in this circle in the middle. You have a healthy islet at the top, and after 25 years, because the specimen at the bottom, the sample was taken from the patient who died after 25 years of type 2 diabetes, very few cells and plenty of amyloid. So we also have this sort of example showing us what happens after hyperglycemia starts. And as I said, it translates into this multiple treatment, but at the very end, at the bottom of this algorithm, we always end up with insulin therapy. I guess we'll be seeing this picture many times during this course. And just briefly at the end, how does this end? Well, it ends with complications, which also makes the treatment of our disease a challenge, because we do not really treat to keep glucose at the normal level. We keep the glucose to prevent the arteries of our patients looking like that. The picture on the left-hand side is a perfectly healthy endothelium. That's a digitally enhanced picture of a healthy vessel. And the one on the right is an aorta of the patient who lived with type 2 diabetes for almost 30 years. And you can see that the wall is severely damaged, and if you heard the noise of the scissors cutting this aorta, you would just hear how it goes through the calcium deposits and how it cracks and how it's difficult to cut this stiff vessel through. So we want to prevent it. So it's not just a treatment just for glucose, it's all about saving vasculature, and we will discuss it in details during these 3 days. So finally, I usually end this talk showing that picture just to make a case for type 2 diabetes. This was published over 15 years ago in a journal for British practitioners. This is a picture of a couple, married couple, they both have diabetes. The picture was taken in Edinburgh in Scotland in a hospital, and the patient who is hospitalized is this man on the left, and you don't have to be very conspicuous in clinical observation to notice a slight asymmetry of his face. He already had a stroke. He was admitted because of the foot ulcer. He also has a kidney failure. He's only 63, as is his wife. And for years he was told that he doesn't have, well, this diabetes is not that serious, just mild touch of sugar. And he died 3 months after this picture was taken. His wife, also of 63 years of age, also has diabetes, but she's got type 1 diabetes since the age of 8. She took tens of thousands of insulin injections. Her only complication is mild retinopathy, and other than that, she's basically okay. So if you think that type 1 diabetes is a serious diabetes and type 2 is just because people are obese and eat too much and they have slightly sugar elevation. That's not true. Even mild glucose elevation is very damaging to the vessels. So this is how it ends, and this is what we want to prevent. So just to conclude, rules for diabetes diagnosis, I didn't mention them, but they are very simple, well defined, and easy to follow. It's not a challenge to diagnose a diabetes, basically. If the glucose crosses certain thresholds, we say, okay, hey, you have diabetes and you need the treatment. But the current classification is far imperfect. It's only based on crude clinical features, mostly absolute versus relative insulin deficiency. And as much as this insulin is needed, with more and more therapies, we are actually able to delay insulin treatment. This rapidly increasing knowledge on glucose metabolism regulation pathways and on genetic traits shows many new or just being acknowledged subtypes of diabetes, and they are difficult today to be easily differentiated, but the tools are coming, and I hope we will be much more able to decide whether the patient needs this or that treatment. This complex pathophysiology therefore makes the choice of treatment difficult, but the two things may be certain: that autoimmune diabetes of course requires insulin therapy, no doubt about it, while non-autoimmune diabetes, whatever type or subtype it would be, may be effectively treated first with lifestyle changes, as we know, but also with increasing number of non-insulin agents, while insulin therapy as needed, because we do not want it, we don't have to escape from it, it actually will be using, and this nowadays we see it being used at an increasingly later stages of the disease, although paradoxically still in many patients we initiate insulin therapy too late, and we will also discuss it during the workshops and lectures during this course. Thank you very much for your attention.
Thank you, Professor Leszek, for this difficult simplicity or simple difficulty lecture. Anyone would you ask a question? Yes, please, go ahead.
Can we have a microphone there?
I would like to ask if there is any future intention to classify diabetes age-related as hypertension. Why diabetes also didn't classify it as that?
That's a very good point. That's a question I ask myself very often, because the strongest risk factor for diabetes is age. In my country, we have good data about it. A quarter of people over 60, and Poland is in the center of Europe, and our society is aging, unlike yours. You're a very young society. But in my country, a quarter, 25% of people over 60 have diabetes. Half of those over 80 have diabetes. But we think, well, at least I think, is it then really so abnormal to have slightly higher glucose when you're 75 or 80? It is definitely not that harmful, because people will not live as long as they would have diabetes when they are 40. But that's a major challenge, if we decided to say, okay, diabetes when you're over 60 or 70 should be diagnosed at a higher levels of glucose. We would need good studies, and also you must be seeing patients like that. We see ladies, they're mostly ladies, men live shorter, but ladies who are 82 and they are as young biologically as other ladies who are like 65, and the other way around. We see people in their 60s who are biologically much more advanced. It's a difficult issue, but I also have doubts whether we are not over-diagnosing diabetes in people who are old. We are definitely over-treating diabetes in people over 80s. We see it more and more often in Europe, and if you come to annual meeting of the AASD, there are lectures nowadays, what should we do not to over-treat people who are in a very much advanced age. But that's the good point. But as you may feel the tendency is the other way around. Just 2 or 3 days ago, Americans decided to lower the threshold for hypertension diagnosis. I will be talking about it in my lecture tomorrow. So we're not moving up with the thresholds, we're only lowering them down. So what we discussed this, but what we'd rather see is that pre-diabetes will disappear, and what is pre-diabetes will be called diabetes, and we will diagnose it when anyone has 100 milligrams of deciliter of glucose.
Any more questions? Yes, please.
Yeah, there's a
We'll
pic-
take
there's a
just
question
2
there.
questions. Yes.
Before treating diabetic patients, are we need to investigate diabetic patients to know pathogenesis of the disease and treat targeting them to targeting the pathogenesis?
That would be a very good thing if we could, for example, decide from the very beginning how much, what's the whatever the phenotype or genotype of the patient is, or how much he or she is insulin resistant or insulin deficient. The problem is that it's kind of difficult, also expensive. Some of my colleagues, for example, when they are not sure, when they have young people diagnosed with, let's say, they think, oh, it's a type 2 diabetes. But someone is not very much obese, let's check what is his or her C-peptide. But if you measure only fasting C-peptide, it doesn't tell you anything. Even people with type 1 diabetes for 5 years duration might have still detectable C-peptide. So to fully assess insulin secretion ability or reserve, you would have to make a glucose test to assess C-peptide or insulin secretion. So then it's become complicated. Much simpler is, especially if you have limited treatment options, if you can only afford, or if your patients can only afford metformin, sulfonylurea or insulin, and all new drugs are expensive, the simpler way is just to give a drug and see if it works or not. And that's what we do in clinical practice. But it's rather the choice, the negative choice, I would say. Yes, we do it because it's the simplest way and the cheapest. But it would be much better if we could look a little bit more deeper into the pathophysiology of the disease. And I think it will happen. Not today, not next year, but in the next decade, perhaps so, yeah.
Last question over there.
Definitely the MODY diabetes needs diagnosis, that I would say. If you suspect MODY, that should be screened or diagnosed genetically. Okay?
You discussed MODY.
Oh, please stand up, please.
Ah,
You,
sorry.
you discussed MODY, 5 types, I know. And now there is MODY.
I can't hear your question.
You discussed MODY. Some of MODY types
Okay.
have, well controlled by sulfonylurea, other by insulin. Okay.
If someone is well controlled with sulfonylurea,
Yeah, but clinically, when you have a patient, for example, you have low resource setting, you know, we cannot identify genetically what happened in this patient. We have to treat him, okay? But how you can we can treat him? You know, some patient no need for treatment, some need.
yeah, that's, well, the answer is in your question. If a patient is treated with sulfonylurea, is well controlled, we stick to sulfonylurea. If it's not, we move to insulin. It's what now we are seeing, what I wanted to say, is just we see that the increasing gap between our knowledge in pathophysiology of what we call type 2 diabetes, and despite we having more and more agents, we choose them only due to efficacy or to hypoglycemia risk, and the costs, of course. But we would have to bind it together somehow. For example, decide, yes, in this patient, incretin-based therapies would work best. But at present, if sulfonylurea works, you stick to it. If they stop, we move very often to insulin, because in many countries, this is the cheapest option. Insulin is usually quite well reimbursed by the governments.
Okay. To to make it easier, you can write your question
No,
in
but
a
we
paper.
we will also have workshops on type 2 diabetes treatment options on Saturday, I think, and I will be happy to answer all your questions or to
I'll-
discuss it.
I'll ask to comment.
Yeah.
Do you dislike the term monogenic diabetes?
Do I?
Dislike the term the monogenic diabetes for Modi?
Do I dislike
You dislike monogenic diabetes, the term monogenic
that
diabetes?
term? I have not such strong feelings about the terms about monogenic. It's a traditional term. It's a traditional term. The geneticists simply said that Modi is an old-fashioned term because it doesn't only affect. It's an old term which develops into, as I said, maturity onset diabetes of the young. But we often diagnose it in people who are in their 40s because nowadays we have the tools. So this is a kind of obsolete term, traditional one. Like if you remember IDDM or NIDDM diabetes. So in many, this was dropped because many doctors who were not diabetologists called every patient treated with insulin, also type 2 diabetes treated with insulin, like insulin dependent, and we understood IDDM as type 1. So I guess we will have a better name because saying GSK Modi or HNF1A Modi is more complicated. Interestingly, more and more those mutations are being discovered. So we will, I guess the new classification will arrive here as well.
Now, Professor Inass Shaltout. Thank you, Professor Lazy.
Thank you very much, and I will be happy to answer any questions, as I said, during workshops or simply during the break. Thank you.
Professor Inass Shaltout is going to speak about the religious diabetes and religious fasting. All it's about Ramadan and Hajj.
Mr. Chairman, dear colleagues, I'm going to talk about diabetes and religious fasting. And fasting is experienced in many religions like Muslim, Jewish, Hindus, Christians, and even Mormons. For Jewish, they fast a few days a year, and for Christian fasting, there are different types of Christian fasting, and one of the most important type is the Christian fasting here in Egypt by Coptic Christians. They fast more than 250 days per year, but this fasting is to stop eating any cooked or cooking with butter or using any animal product like eggs, milk sometimes, and butter, meat and poultry. There are different types. Some types they can permit fish eating. Some types of fasting cannot permit fish eating. So these different types are according to days during the year. And the most important thing that we can do patient education for those patients. And my colleague here, Nagla, gave instructions to diabetic Christian Coptic patients in churches how to take their meals to avoid high blood glucose, because they usually use lots of oil, and this may lead to hyperglycemia and sometimes dyslipidemia by the end of the fasting days. So now we move to Islamic fasting, and we have 1.6 billion adherent Muslims according to 2010 demographic data, and expected to have 2.2 billion Muslims by 2030. And according to the global prevalence of type 2 diabetes, which is around 8.8%, and according to the EPGR study, one of the most important studies done on more than 11,000 diabetic patients fasting during the holy month Ramadan, that there is an estimate of more than 100 million diabetic Muslim patients worldwide every year. Muslims usually fast during the holy months of Ramadan and also in different religious occasions around the year. The AASD did a study called Diabetes and Fasting, and we found that 97% of type 2 diabetic patients fast during Ramadan in spite of some instructions by their physicians not to fast, but they usually fast. But some of them didn't complete the fasting. Patients who complete fasting during Ramadan were 79% of cases. Those who fasted more than 20 days of Ramadan were 7%, and those who fasted less than 20 days were 12% of the patients. The risks of fasting include the progressive increase in the number of fasting hours happening during summertime. And with hot weather, this is will add to the problem of fasting with no foods or no water even. 4 major risks of fasting include hypoglycemia, hyperglycemia, diabetic ketoacidosis, dehydration, and thrombosis. But let those patients take the reward of fasting if they can, because they are going to fast anyway, so we should help them to fast. We have 3 high-risk groups, and the first one is the high-risk patients, type 1 diabetic patients taking too much units of insulin, severe hypoglycemia within the last 3 months before Ramadan, patients with history of recurrent hypoglycemia or hypoglycemia unawareness, ketoacidosis or hyperosmolar coma 3 months before Ramadan, patients with sustained poor glycemic control, patients with renal insufficiency, patients with advanced macrovascular complications, comorbidities will add any additional risk factors. Acute illnesses, and of course, pregnant ladies should not fast. And the Islamic religion give instruction if the lady is pregnant without even diabetes, she should not fast. Those are the moderate risk patients, including patients with moderate hyperglycemia, patients living alone, treating with insulin or sulfonylurea, patients living alone with ill health, old age with ill health, drugs affecting mentation, and patients who perform intense physical work categories. The third group is patients at low risk, and this group includes patients who are well controlled on diet or non-hypoglycemic anti-diabetic medications like metformin, like dipeptide peptidase inhibitors, like thiazolidine-diones and GLP-1 agonists, and they are otherwise healthy patients. They can fast without even medical advice before Ramadan. And we had this fatwa from the higher religious authority. The AASD took the fatwa from the religious authority, Dar al-Ifta, who should fast and who should not fast, because we can convince the patients and convince the doctors if there is high risk, if they fasted, we should instruct the patients not to fast, and we should tell the doctor when to give instruction to the patient not to fast. And the fatwa is very convenient. They say whenever the doctor sees that the patient should not fast, you should give the patient the instruction not to fast. For a safer fasting, There should be a pre-Ramadan medical assessment, and the assessment through possible treatment change, and also to make a patient education. Meal planning, dietary advice, exercise, how to make exercise during Ramadan, because it's famous that people go to the clubs just before the breakfast, while there is high sympathetic overactivity, and they do exercise. This is proved to be of risk to the diabetic patients, maybe also cardiac patients. Blood glucose monitoring and recognizing and managing complications like hypoglycemia and hyperglycemia. You should inform the patients about the symptoms of hypoglycemia and how they should break the fast if any hypoglycemia happens. For lifestyle modification and dietary instructions, glycemic foods should be taken into account, because it's very famous during Ramadan to eat sugary desserts, sweets taken in Ramadan with high sugar content. They may necessitate change in drug therapy. And foods like onion and garlic, they are hypoglycemic, and medication or dietary tips may be needed. For lifestyle, we know that Muslims have the tradition of eating dates, especially in Ramadan, so we should minimize the number of dates. This is usually taken when breaking the fasting at breakfast. At the sunset, they usually eat dates, so we should minimize the number of dates to either 1 or up to 3 only, not more than that. Maybe they can take it with some tea or some coffee, because the patient may be they're fasting for 16 hours up to 17 hours in some countries, so they like usually to start with some sugary diet like dates. This is a table in Ramadan, so we can imagine how fasting Egyptians and Arabs and Muslims eat during breakfast. This is usual in every house in Egypt during Ramadan. The Arabic Association for the Study of Diabetes and Metabolism made flyers to educate people how to take their meals. They start with the date, one date, then the soup without any cream or any butter or something like any fatty constituents. Then how to take the carbohydrate in the form of either bread, brown bread, or rice. Then the vegetable amount, they can use lots of vegetable if they need, and the protein and how to cook the protein. And for the juices, because it's very famous also in Ramadan to drink juice or soft drink, or sometimes they are very sugary. Then we should give the patients some instruction how to make low calorie juices, or sometimes diet soft drinks. The patients tend to eat desserts and sweets after breaking the fast, so we can postpone these sweets and give very small amount of sweets after the prayer, because usually they go to the prayers, they make some exercise and some movement and lose some calories, then they can come to take a small amount of the dessert we saw in the previous photos. Before the dawn, they take another meal, and we should instruct the patients to take a good meal before starting the next day fasting. So this meal should contain a certain amount, fixed amount of carbohydrate, and they should take care of this meal because they are going to fast for 16 hours or 17 hours. So they should take care of the suhoor meal. Exercise in Ramadan, we said that people go to the clubs, but also Taraweeh prayer is considered as an exercise, and the timing for Taraweeh prayer is very suitable for diabetic patients because it's around 1.5 hours after the main meal, the breakfast meal. So this time is very suitable for diabetic patients, and also the exercise during Taraweeh prayer is considered a good exercise and energy loss or calorie loss, which is suitable to get rid of the calories taken during breakfast. For managing diabetic patients during Ramadan and the oral anti-diabetic medications, and let's start with metformin. There is no change in metformin dosage during Ramadan, but if the patient is given one single dose, it's given with breakfast. If the patient is given long-acting metformin, then the whole dose can be given with breakfast. If the patient is given 1,500 milligram metformin, we can give 1,000 with breakfast and 500 with suhoor meal, the meal before dawn. For sulfonylurea, if the patient is well controlled, there may be a need for adjustment of the sulfonylurea dose. We can minimize the sulfonylurea dose, and if the patient is taking one daily dose, it can be given before iftar. If the patient is given twice per day, we can give one dose, full dose before iftar and half the dose before suhoor. And it's convenient now that we are having the newer sulfonylureas, which is less hypoglycemic and can be used with safety. And there was many studies done on second generation sulfonylurea, and they proved to be safe. But if the patient is very well controlled with well controlled hemoglobin A1C and fasting and postprandial blood glucose, it's better to reduce the sulfonylurea dose a little bit. For short-acting insulin secretagogues, they can be taken before meals, and we can give the whole dose before iftar, and to reduce the dose before suhoor, because the patient is going to fast for around 16 hours. For acarbose is safe, and we can give the whole dose, and it's good for some reduction in glucose absorption in those patients because they are already taking higher doses of glucose and carbohydrate. For the DPP-4 inhibitors, they have low risk of hypoglycemia and no adjustment of dose is needed, so we can use the DPP-4 inhibitors very safely during Ramadan, and there are many studies done, and one of them is the Virtue study. I had the honor to be one of the investigators. It was vildagliptin experience in diabetic patients fasting during Ramadan versus sulfonylurea, and it proved to be safe, the vildagliptin. So we are having all the DPP-4 inhibitors are proved to be safe during the holy month Ramadan. It was multicentric, more than 1,000 patients. The patient with more than one hypoglycemic event, the number of patients in the sulfonylurea group was 123 patients compared to 36 patients in the group receiving vildagliptin, while 0 severe hypoglycemic attack in the patients receiving vildagliptin versus 4 severe hypoglycemic attacks in patients on sulfonylurea. And now the summary. A pre-Ramadan assessment is vital. Patients should come at least 1 month before Ramadan. It's not correct that the patient is coming at the first days from Ramadan and say, I'm here, so please adjust my medication. It's better to have the patient 1 month before Ramadan to make the blood glucose, to make the hemoglobin A1C, to give education about the lifestyle, the diet, to give a flyer for dietary choices, and to give that chance to patient to enjoy Ramadan, but with low risk of either hypoglycemia or hyperglycemia. Ramadan provides an excellent opportunity to initiate healthy lifestyle changes. Sometimes the patient is in challenge. I'm not going to complete Ramadan except if I try my best to adjust my lifestyle, my food, and my exercise. Motivation for self-improvement is high at this time of the year. That switch in eating pattern breaks, provides habits and weight loss goal. We see this passion in our patients, so they are keen to fast during Ramadan, so we can try to make some lifestyle changes during Ramadan. Thank you very much.
Thank you, Professor Inass, for your elegant clinically applied talk about diabetes and religious fasting. Now we will open for the discussion. Any question, please? Yeah.
Thank you, Professor Inass, for this elegant lecture. I am a professor of pediatric endocrinology. So, I ask you about type 1 diabetes. Do you recommend fasting for them as a general rule, or select the best patient for fasting? And what are the precautions during fasting as regard type 1 diabetes? Thank you.
For type 1 diabetes, there is a recommendation that they shouldn't fast, but because they are keen to fast, and we know that, and Egyptians, up to 97% of Egyptians fast during Ramadan, maybe those patients who are in good control and they use small amounts of insulin. If the patient is needing too much units of insulin, or 4 times insulin a day, I think it's impossible to let him fast, or let these patients fast without complication. So if the patient is using smaller amounts of insulin and his blood glucose is well controlled with no hypoglycemic attacks or hypoglycemic coma or diabetic ketoacidosis for months before Ramadan, we can try fasting. But also for older patients, not for young, because we have children here in Egypt who try to fast even if they are diabetics.
Professor Inass, what about the SGLT inhibitor and fasting?
SGLT were supposed previously that they are not safe, but there is data that they are safe. They started to make research on SGLT2 inhibitors, and just the recommendation was not to start the SGLT2 treatment at the beginning of Ramadan. It should be started before Ramadan because of the fluid loss that may happen.
I think it is very difficult to use SGLT during Ramadan, especially in hot weather, because of dehydration.
I think it's corrected within few days, up to 1 week. this was the recommendation, because this dehydration and loss of fluid is corrected in 1 week. So we can start them 1 week at least before Ramadan. Or if the patient is taking them regularly, we shouldn't stop, because there is data about safety. There are studies about safety.
Thanks, Dr. Inass, regarding this presentation. I have one question similar to that question regarding type 1. GDM women, wide variety, including from diet control up to insulin. These GDM women sometimes insist to fast during Ramadan. And we try to help them to avoid fasting, but they insist. So we try to reduce the dose of insulin or some sort like that, and they can come after Ramadan. This is the first question. Second question, we are happy with this guideline regarding the fasting during Ramadan. Are this in the future we can see guideline regarding Hajj or Umrah?
Hajj or Umrah. For Hajj and Umrah, let me start with this. This is a religious duty done to Hajj to Mecca in Saudi Arabia. For Hajj and Umrah, from experience, we give some instruction. So we wrote the instruction and flyers for Hajj and Umrah. Okay, it's not a guideline, but they are instructions. For gestational diabetes, you should try your best to convince the patient not to fast, because Islam said that the pregnant lady who is not diabetic should not fast for the benefit of the baby, not for her benefit. If she fasts and then she will have a baby with some medical problem, it's not forgivable. So you should convince her to not to fast at all, please.
Ramadan. What is the best time for long-acting insulin?
During Ramadan, using long-acting insulin?
What is the best time?
Okay, maybe the slides here were I didn't have enough time to talk about insulin, but if the patient is well adjusted on an insulin dose, you will try to reduce the dose by at least 30% of the dose. And if you're giving mixed insulin, you're going to give the main amount with breakfast and a smaller amount, if any, with suhoor. If you are taking a long-acting or basal insulin, then you should reduce the dose if the patient is well controlled.
Timing of glargine.
Time of basal insulin?
Yes.
Regular time before Ramadan. It can be used. The insulin injection doesn't break the fasting. So the patient, if the patient is taking it in the morning, he can take it in the morning. You can gradually, you can shift before Ramadan, but it's not forbidden to use the insulin during Ramadan.
Thank you, Professor Inass. The fourth talk about bariatric surgery and diabetes by Dr. Ahmad Bashir.
Thank you, Mrs. Chairman, Mr. Chairman. I would like to start by thanking the European Association and the Arabic Association for the study of diabetes to allow me to present this talk. I come from Jordan. I'm a bariatric surgeon. I'm actually half Egyptian. My mother is Egyptian. Congratulations to Egypt on making it to the World Cup. We're rooting for Egypt next year, definitely. I would like to start by a show of hands. Who refers patients for bariatric surgery? So I have a tough crowd to convince that bariatric surgery actually works. And who considers bariatric surgery safe and effective? What about bariatric surgery is effective but dangerous? The majority of the rest of the crowd. Okay, so we'll go ahead and start. these are my disclosures. I have no financial disclosure. By practice, I'm a majority Roux-en-Y gastric bypass surgeon. I do other surgeries as well as revisions. But what I'm going to tell you is diabetes, as we talk, type 2 diabetes and obesity epidemics are on the rise. And the burden, especially in our region, given our financial limitations, is huge. And the International Diabetes Federation already recommend bariatric surgery for type 2 diabetes and obesity, but we're still not implementing those recommendations. Despite having level 1A evidence with randomized controlled trials showing superiority of bariatric surgery with intensive medical treatment, and I stress both, to intensive medical treatment alone on the long term. So we're going to talk a little bit about the burden of diabetes, and it was mentioned earlier, and the new International Diabetes Federation guidelines, some of the randomized controlled trials, and why does bariatric surgery work better on the long run, and the new wonder pill vote for a new medication, and the challenges that we face in our region. So this is the newest International Diabetes Federation Atlas published in 2017, and it shows the difference in our region and all the rest of the world between now and 2045, and the expected rise in diabetes numbers. For us, we lack the financial support. If you see the orange circle, that's the Middle East. Middle East, we can't afford to spend as much as the rest of the world because we are in a huge financial deficit. But a lot of the patients are actually undiagnosed, and we have a high rate of early death due to diabetes in our region. Again, the orange circle. And the prevalence of diabetes in our world is quite high. Egypt is considered one of the highest as well, and it increases with age. And if we can see, the regional preference is approaching 10%, and it's going to go up to 12.1%. And the number of people diagnosed with diabetes in our region will be 82 million. And the number of deaths at 2017 is quite high. And the total amount of money that we spent expected to be 35.5 billion. And that's a huge number given the financial limitations in our part of the world. Egypt is already on the top 10 list as far as the adults with diabetes, the number of adults with diabetes. And it's still going to be on that list in 2045, according to predictions. And it's high on the list as well on undiagnosed diabetes, top 10 countries. And in the International Diabetes Federation guidelines, if a patient with type 2 diabetes comes with obesity, we should recommend bariatric surgery. And we should recommend bariatric surgery as a first primary option for body mass index more than 40. And we should discuss it and recommend it for patients with uncontrolled diabetes, for BMI more than 35, and consider it for uncontrolled diabetes between 30 and 35. And these are the recommendations. And for Asians, it drops down to 27.5 as far as BMI. But why did we come to this conclusion? Why did the International Diabetes Federation come to this conclusion? The different bariatric procedures, the Roux-en-Y gastric bypass is considered the gold standard, and it's been done since 1965, and we have a lot of data on the Roux-en-Y gastric bypass, and majority of the randomized control trials are done on the Roux-en-Y gastric bypass as part of the study. The commonest bariatric procedure nowadays overall is the sleeve gastrectomy, but we're starting to see the long-term effects of sleeve gastrectomy, and some of them are actually not as good as we wished it to be. And the metabolic control over longer periods of time is actually lower. The new kid on the block, which is the single anastomosis gastric bypass, or the mini gastric bypass, as many call it, it's gaining popularity, especially in our region, and we lack long-term studies, especially on diabetes and randomization. The duodenal switch is considered, or the biliopancreatic diversion, is considered the scariest procedure. It's scary even for surgeons. But the metabolic effects of biliopancreatic diversion and duodenal switch are the highest, and it's the most potent metabolically. And the one procedure that is losing popularity is the gastric band, although it's still effective in treating obesity and diabetes. So we'll start with the first randomized controlled trial, the gold standard Swedish obesity study. This is where a lot of the obesity science stemmed from Dr. Lance Swanström and colleagues in Sweden, and they published their data over the long period of time. And what they studied is they compared two arms, one surgical arm and one control arm, obese, matched in 14 different factors, and they followed those patients up for 20 years. And the size of the population was actually significant, more than 2,000 in both arms. So what they found is a significant weight difference between the patients who did not undergo bariatric surgery, the control group, and the different bariatric surgeries done. And those were done open, those were more complicated procedures back in the day. And despite having more surgical complications then as opposed to now, the overall mortality was reduced by 30% in the bariatric surgery group. The cancer mortality was the most common overall, but the cancer mortality itself was reduced by 39% in the surgical group, and the cardiac mortality was reduced by 56%. And in that study, they found an initial high remission rates of diabetes, and you can see, you can see that the first top graph, that reduces with time, actually, the remission rates, the complete remission from diabetes. And that's what we see in the randomized control trials nowadays. But the fascinating part of the study is the ones who did not have diabetes had less prevalence of diabetes in the surgical arm compared to the control arm. And that's actually over a long period of time. And it's reduced by 78%. And the lowest risk group was found in the Roux-en-Y gastric bypass group, so which makes it the most metabolic procedure between the procedures that were studied in the Swedish obesity study. And the fatal and non-fatal cardiovascular events were reduced in surgery as opposed to the control group, and they were reduced significantly. The incidence of atrial fibrillation as well. And cancer was more reduced in women as opposed to men in the Swedish obesity study. And the most fascinating point, the best benefit was found in the patients who had high insulin, high baseline insulin levels. And other comorbidities like hypertension, obstructive sleep apnea, triglycerides, arthritis, even the ventricular mass was reduced after bariatric surgery. And the best part is the quality of life was improved for patients over a long period of time. And as far as money, the most cost-effective group was actually the ones who had diabetes to begin with. So Sweden is a national insured, no patients pay for their health insurance. So the country actually sees all the financial implications of surgery, and the highest benefit financially was for patients who were diabetics. So the medical community actually started recognizing this epidemic back in 2007, and they met for the first World Congress on International Diabetes Therapies. And they looked at the evidence that was available back then, and it was few retrospective studies. Some of them were prospectively collected, and they concluded that we needed randomized controlled trials to study bariatric surgery and the effect of bariatric surgery on obesity. And this is by far the gold standard of randomized controlled trials for bariatric surgery, and we call it the Stampede trial from Cleveland Clinic, Dr. Phil Schauer and colleagues. And they studied randomized 150 patients between intensive medical treatment, Roux-en-Y gastric bypass, and sleeve gastrectomy, and they had an amazing 90% follow-up at 5 years. And they looked at a primary outcome of hemoglobin A1C less than 6 with or without medications, and the secondary outcomes, complications of diabetes, surgery, effect on comorbidities, and number of medications used. And these are the baseline characteristics, and once they actually started randomization, unfortunately, eight patients refused to continue the study in the medical arm, 1 patient in the sleeve gastrectomy arm, and they eventually ended up with these numbers. And the sickest patients were actually in the Roux-en-Y gastric bypass group as opposed to the rest, and but they were statistically insignificant. And these patients did not represent the regular population. These patients represented the endocrinology clinic population in the Cleveland Clinic, and this is important. And what we saw is a significant decrease in hemoglobin A1C. This laser is not working. In the top left corner between the control group, which is the intermittent dotted lines, and the sleeve gastrectomy and the gastric bypass. And significant reduce in the number of medications. And patients who were not on medications after 5 years were 45% of the gastric bypass group and 25% of the sleeve gastrectomy group, while it was only 2% in the intensive medical treatment group. And in the intensive medical treatment group, they actually had reduced number of medications, which is actually significant. But the increase in weight was seen in the control group. 20% of the patients actually had weight increase, and the weight decrease in the surgical arm was more significant, definitely. And the glycemic control over time was better between different BMIs, even less than 35 and more than 35. And this is the first level 1 evidence in different BMIs, even less than 35. And this is the breakdown of the medications used in that study. And you can see the difference at baseline and a difference at 5 years. It's a busy slide. I wish I had the pointer working. The adverse events, the only mortality in that study was seen actually in the medical therapy group from a fatal myocardial infarction. 1 patient in the sleeve gastrectomy group had a stroke. The surgical arm had unique complications, post-operative complications, but they were early on in the first 30 days. Later on, the long-term complications were seen related to the sleeve gastrectomy, as far as reflux was higher in the sleeve gastrectomy as opposed to the control group. And the nutritional outcomes. The fascinating thing is anemia was more common in sleeve gastrectomy, which we sometimes actually advertise as you don't need any vitamins with sleeve gastrectomy. But anemia was more prevalent in the sleeve gastrectomy arm as opposed to the rest of the study. And the quality of life at 3 years was much better in both sleeve gastrectomy and Roux-en-Y gastric bypass. Actually, the gastric bypass had a better quality of life using the 36 questionnaire. And at 5 years, it continued to be better, although the emotional well-being was reduced, especially in the gastric bypass group on the long run. And since the Stampede trial, we had plenty of randomized control trials. they compared gastric banding, Roux-en-Y gastric bypass, biliopancreatic diversion, but a lot of studies over the amount of time. And they were all combined in this meta-analysis by Dr. Muller-Stitch and colleagues, and to look at the effect of bariatric surgery versus the control. And you can see the remission rates. There were very few remissions with intensive medical treatment in any. The glycemic control was more obvious and evident. And the hemoglobin A1C average numbers, mean numbers, you can see in the surgical arm as opposed to the control arm, were significantly better. And they looked at the different types of procedures and the effects of diabetes control, and it was more pronounced in the biliopancreatic diversion and the Roux-en-Y gastric bypass as far as remission, glycemic control, and the change in hemoglobin A1C from baseline medical treatment. So that actually ended up in the Diabetes Surgery Summit in 2016, which combined a lot of international societies, and they looked at recognizing certain bariatric procedures as metabolic procedures. And finally, bariatric surgery made it to the treatment algorithm. And the treatment algorithm, as I mentioned earlier, for BMI more than 30, BMI more than 40, with type 2 diabetes, bariatric surgery should be recommended. For patients who have body mass index of 35 to 240, if they have uncontrolled diabetes, then they should be recommended to have bariatric surgery. If they have controlled, then we can consider bariatric surgery as an option, and that's lacking in our practice. For patients who have body mass index between 30 and 35, if they have uncontrolled diabetes, we should consider bariatric surgery as an option of treatment. But if they're controlled, consider non-surgical treatment and continue medical treatment. What's unique about surgery, it affects a lot of targets. This is a study by Parking and colleagues in 2014 looking at the pathophysiology of how Roux-en-Y gastric bypass works. And this image is amazing and fascinating, and I recommend that you actually keep it in your memory till the end of the talk. So it actually affects hormone, increases the incretins and reduces the diabetogenic hormones, decreases hunger, increases energy expenditure, increases beta cell function and insulin sensitivity, and reduces bile acids and changes the gut microbiota, which is very important in the pathophysiology of obesity and its comorbidities, and increases HDL and lower LDL. And it changes the perception of food, reduces fat preference and reduces actually sweet preference. So, and looking at the gut microbiota, the diversity is highest between all procedures studied in the gastric bypass group. So why is it that we don't implement these guidelines? And I think it goes back to our view on obesity. The most fascinating study that was published by Dr. Fothergill and colleagues in 2015, actually, the Biggest Loser study. We all know the Biggest Losers and how they're actually supervised by professionals to medically or non-surgically lose weight. And these patients were followed over 6 years. And all of them actually, unfortunately, regained their weight back. And they even measuring resting metabolic rates after regaining the weight did not return back to normal. this actually study changed our perception on obesity. And human body is one fascinating machine that is extremely efficient in conserving energy. And obesity is a chronic disease, and it is a chronic disease, and we only recognized it as a disease in 2014, unfortunately. And this is one new article, actually, by Dr. Lee Kaplan that was published in October 30th about the perceptions and the barriers to effective obesity treatment. And I recommend all of you to read it. And they actually surveyed patients, 3,000 patients, and more than 500 healthcare providers and employers, actually, to get their perception on obesity and what is the best modality of treatment. So only 71% of healthcare providers discussed weight in the past 5 years about patients, and only 55% actually were diagnosed with obesity, and only 24% of healthcare providers scheduled a follow-up visit related to obesity treatment. And why was the discussion not initiated? 52% of healthcare providers said it was due to the lack of time, or there were other important issues to discuss, or I do not believe that patient is motivated to lose weight, and a lot of other reasons. And if you look at this, this summarizes the study. Our patients, and these are the US patients, and 65% of them think obesity is a disease. And 20% of healthcare providers in the US do not think obesity is a disease yet. 80% is a good number, but 20% not recognizing obesity as a disease is an issue. And majority of patients think, they're to blame as far as their obesity. Obesity is not a choice, it's a disease, and we should remove this stigma in 2017 and recognize it as a disease and recognize the effective ways of treating it. And only 62% of healthcare providers looked at weight loss surgery as a good option for treating obesity. And 40% of the US population, as far as patients-wise, do not think, or 60% do not think it's effective treatment. So we need to change these perceptions. So I'll challenge you with this. If we have a magic pill for obesity and diabetes, if I tell you that it increases GLP-1, increases PYY, decreases ghrelin, decreases leptin, and decreases LDL, increases HDL, and decreases bile acids and changes gut microbiome, and increases beta cell function and insulin sensitivity, and decreases hunger and increases energy expenditure, and decreases sweet preference and decreases fat preference, would you prescribe that pill? I guess majority of us would, but until that pill comes, Roux-en-Y gastric bypass is considered the safest. So, and for those who consider bariatric surgery is dangerous, I'll tell you what, there are a lot of studies that look at mortality, and bariatric surgery, you'll see the survival rate. It's the top line. The mortality from bariatric surgery is lower than a cholecystectomy. And these are huge numbers, and this is what we should aim for. It's really not dangerous at all. It's safe and effective, and both of them are safe and effective long-term in treating diabetes and obesity. So in conclusion, type 2 diabetes is on the rise along with obesity, and the burden in our part of the world is going to be higher. The International Diabetes Federation recommends bariatric surgery with patients with obesity, and we have level 1A evidence, and it's time to actually implement those guidelines nowadays. we have to bypass the obesity stigma, and bariatric surgery is safe. Thank you.
Thank you, Professor Ahmad, for your elegant illustrative talk. I would like to have some questions. The first one about the use of GLP-1 versus different type of surgery, whether sleeve or gastric bypass. Is it the same, or the gastric bypass or sleeve much more?
It depends on the type of bypass, and the the more distal the bypass is. If we bypass a lot of the small intestine, your GLP-1 levels will be higher. The faster the food gets to the Y cells in the ileum, the higher the GLP-1 will be secreted. So in Roux-en-Y gastric bypass, it is higher. It does rise in the sleeve gastrectomy. We don't have long-term studies on GLP-1 and PYY over the long term after metabolic surgery. It's something to look at.
Yeah. We looked for the advantage only of the bariatric surgery, but we didn't look for the side effect of bariatric surgery. And we will find after a time there is some side effects as regard reflux esophagitis,
Yes.
Some of the side effects that puzzle the patient.
Yes. I mentioned in the Stampede trial, the incidence of reflux at 5 years actually was 27% in those patients, and those were only 50 patients. Nowadays, in sleeve gastrectomy per se, we're starting to see not only reflux, but some reports about Barrett's esophagus in patients who did not have reflux or any esophagitis in the past. And that's why long-term outcomes of sleeve gastrectomy are not yet to be defined. That's why I advise patients who want to have sleeve gastrectomy per se to undergo endoscopy annually until we actually answer that question. But anything that we do will have side effects. Any intervention that we do will have side effects. But the benefits are huge for bariatric surgery, especially for patients who have obesity as well.
The third, as regard the beta cell function, you mentioned that there is improvement of the beta cell function.
Yes.
But with the time, there is recurrence of diabetes after 3 or 4 years.
Dr. Mingroni actually in 2017 published his randomized control trial looking at BPD, Roux-en-Y gastric bypass versus control. And it's one of the randomized control trials that I showed you, and it was included in the meta-analysis. And he showed 43% relapse of diabetes on the long run after 5 years. So we're not talking about remission. As bariatric surgeons, when we started talking about diabetes, we have the cure for diabetes. It's not a cure. It's temporary remission. The chances of remission are higher, and the chances of remission are better the faster we intervene. So if you have a patient with severe diabetes, that patient's remission rate will be much, much lower than a patient who have early diabetes with good beta cell function, a good beta cell mass, and a pancreas that is able to produce insulin. Whereas severe diabetes has lower remission rates with bariatric surgery, and that's definite and very well studied. But the two combined on the long term is much more effective than either alone. And this is where we should work together as bariatric surgeons and endocrinologists on tackling this burden long term.
Lastly, what we found here in Egypt, that some physicians prefer to do surgery, bariatric surgery, for a patient with body mass index less than 35. Just this for the treatment of diabetes. And I think, I doubt it is something, it's very bad.
It's actually in the International Diabetes Federation, it is considered as part of the treatment, and it should be considered as part of the treatment, especially in patients who have uncontrolled diabetes, if we follow the algorithm. And there are a lot of randomized controlled trial, even in BMI less than 35. But I caution, surgeons, endocrinologists, Dr. Scopinaro, who is the founder of IFSO. He's an amazing scientist. He studied the effects of bariatric surgery on the beta cell mass between patients with body mass index less than 30 and more than 30. And it seems that bariatric surgery and the pathogenesis of type 2 diabetes in the non-obese is different than the patients who have obesity per se. It does not affect the beta cell function as much, and the remission rates and the results are poor in body mass index less than 30. That is well studied as well.
Thank you. Yes, Abir.
Very short questions and very short answers. First, about initial screening of vitamin D level, because there is rising evidence of the presence of hypovitaminosis, the polymorphism in type diabetes. Do you routinely screen for the vitamin D level for patients who are going to have a big operation like RO&Y?
Yes, we do. We screen for not only vitamin D, but a lot of other vitamins and minerals before surgery, because part of the pathogenesis of diabetes is the malnutrition of the wrong types of food. So patients what we found is actually in our patient population, more than 70% have deficiencies beforehand.
Other issue about the doing this RO&Y, this large disastrous operation for obese type. Do you have any data supporting or going against? Of course, I think there are data against this, but we find patients in real practice who are obese type 1.
Type 1
who are operated upon.
Type 1 is completely different than type 2, and we all know that. But in my patient population, I have one patient with type 1 diabetes. I can tell you about my anecdotal. We don't have a lot of reports, these are case studies, but it decreases insulin resistance and improves it reduces the number of insulin units used by patients, especially with patients with obesity. But who are non-obese, for treating type 1 obesity, this is...
If I may add, we were actually the first ones to describe the long-term. It was a case series, like 5 cases. We described it 10 years ago in Diabetes Care. In type 1 patients who underwent gastric bypass, Roux-en-Y gastric bypass, because we are also more in favor of this surgery. And basically the results are okay. If you have an obese type 1 patient, achieving good metabolic control is almost impossible in type 1 with obesity, and bariatric surgery is often the only option. So if we have, there are rare cases, but usually young people in their 20s or 30s, so if they accept our suggestion, we do refer them for bariatric surgery. And now there are a number of case series studies. I even saw one meta-analysis or systemic review on type 1 and obesity treated with gastric bypass surgery.
The management difficulty after this, when you administer the insulin, there are management difficulties about the duration of delivering insulin. The transit time will be reduced, of course, in the Roux-en-Y operations. A lot of important issues which will reveal after the operation. It's
Yeah, this peri-surgical period is difficult, but otherwise later it really works. So we simply don't treat type 1 diabetes as a contraindication to bariatric surgery. It's rather the opposite. It's what you're stressing out, that we don't really do bariatric surgery in diabetes to make people lose weight, but to achieve better control of diabetes. That's the goal for the treatment.
Finally, the healthy obese. You consider obesity as a disease. There is a rising evidence about the healthy obese, the metabolically healthy obese person who has most of his fat, the subcutaneous region, not considered to be an innocent fat. I mean, most of his fat is not the visceral bad guy.
You know,
just a comment about it.
Yeah, I asked this question to one of the scientists, Dr. John Dixon, the paradoxical obesity, the healthy obese. What he said is they haven't shown their metabolic effects yet. Just wait until they show it. So.
The two first questions. One, which patients that you, in good practice, should not be referred to you, and in good practice, you will not operate as a bariatric surgery? This is one. The second, if you do a bariatric surgery with a success, with the tackling down of the status of the patient and his cognition of his body, this is an issue I wrote an article about. Thank you.
You know, bariatric surgery is all about health. It's not about, body image. And I always discuss with patients realistic expectations prior to bariatric surgery. You know, a lot of patients come in, they're imagining they're going to be supermodels after. That's not our aim. Our aim is health, first and foremost. And, it should have guidelines, and every practice should have guidelines for, approving to do bariatric surgery and disapproving certain patients. A healthy patient who does not have any metabolic issues, BMI 31, 32, they're not candidates for bariatric surgery, even up to BMI of 35. But patients with comorbidities and body mass index more than 35, I would do bariatric surgery for.
Yeah. Patient experience hypoglycemia.
Reactive hypoglycemia after bariatric surgery, and you see it more often with Roux-en-Y gastric bypass as opposed to other procedures. It is actually, we see it in even sleeve gastrectomy patients. The majority of the patients are actually very well controlled if they change the way they eat, the eating habits, small frequent meals, and that's why I advise patients avoiding high sugar loads, high carbohydrate loads. That's definite, especially in Roux-en-Y gastric bypass. You're gonna tackle, as the more you do, the more you'll see this as a symptom. But in our practice, when we looked at that, and even in the Stampede, it's almost the same. Stampede trial mentioned about 10%. In our patient population, 11.1%. The severe hypoglycemia that is uncontrolled with diet modifications, then we use certain medications to control it, like acarbose, or sometimes we use octreotide subcutaneously, and majority of patients respond. The fear of necidioblastosis, or new onset necidioblastosis, and the patients who require pancreatectomies. I worked with Dr. Kelvin Higa, and he is one of the most renowned bariatric surgeons worldwide, and under his belt is more than 12,000 patients, and he has not seen a patient with that required pancreatectomy for hypoglycemia. But it's mentioned in the literature, and that's one of the fears that endocrinologists always ask about in conferences. But myself, I've never seen it before, and hopefully not.
Thank you, Professor.
Well, what are the factors that guide our choice of the surgery type? Is this the surgeon experience only, or the patient factors like eating patterns, cardiovascular risk, and age of the patient?
You know, if you ask this question to a lot of bariatric surgeons, it's probably a surgeon's preference will dictate what he advises for patients. But based on data and the procedures that are studied, bypass operations are better for controlling metabolic diseases like diabetes. Sweet eaters, I say Roux-en-Y gastric bypass as far as sweet preference, because it reduces the sweet taste and the preference for fat through dumping. That's definite. A patient who has reflux, I would not advise sleeve gastrectomy for, never, beforehand. And every bariatric patient should undergo preoperative endoscopy, because you have 10 to 14% who have silent reflux and they don't know it. So every patient should get that study prior to dictate where you go. The new bariatric procedure, single anastomosis or mini gastric bypass, it's quite effective, but you know, the longer term studies, we're seeing more and more bile reflux, more and more even gastroesophageal reflux, acid reflux as well. So those patients, I would not advise, the reflux patients, I would not advise single anastomosis as well.
Yeah. Thank you very much, Professor Ahmad Bashir. Now we will shift the second session. The chairperson, Professor Hisham Habib, Professor Nader Wadia, Professor Omar Saadani.